So, welcome, my dear postgraduate students. I hope you had enjoyed the slide for the previous class, done your homework, and come back with enough amount of knowledge and confidence. To recapitulate the history, this is a lesion from a 65-year-old male with gradually increasing hard of hearing. Hard of hearing is the same as loss of hearing. What I would like you people to appreciate from this picture is there is a sense of regularity amidst irregularity. I find that there are glands of varying sizes, and in some areas there are some solid strands, etc. But then there is a definite pattern, which is one of the fundamental advantages of histopathology. Also, I am able to find some weird structures over here, not usually seen. But this again is a tumor. This is a normal component of the tissue. So, what is the diagnosis? We shall see in the glide the slide, the 7th class for today. The diagnosis here is adenoid cystic carcinoma. Now, the diagnosis depends on the location and the perfect history as such. Introduction. It is a rare malignancy, can occur in any of the secretory glands, including the salivary. Minor salivary glands, it is greater in number. It can occur in the head and neck malignancies, lacrimal gland for example, and forms 10% of the slowly growing tumors. The tumor as such is slowly growing, and there is a chance of a perineural. That is what we had seen in the previous class. And there is also a hematogenous mode of spread. Gross doesn't give us much of information because the lesion is ill-defined, infiltrative, but firm in consistency. Hard is a word that we should use generally for bone and tooth. Occurs in the elderly, and my history says about 60 or 65 years. Associated with 80 ACC genomes. There can also be a deletion of the chromosome 1p, 35-6 segment. Translocation 6q9p is also possible, leading to MYC-NF5p fusion. So this is supposed to be, the MYC is supposed to be the catch in this particular lesion. The other sites, as I had mentioned, it can occur in the lacrimal gland, the palate, the nasopharynx, the tongue, the breast, the respiratory system, trachea, even the skin. But basically, it is a glandular lesion. Slowly growing, asymptomatic, rarely metastasizes. And the most common organ for metastasis is the lung. Liver can be there, intracranial, particularly depending on the location. When it is nasopharyngeal, the patient can come with a complaint of epistaxis. Eustachian tube, there can be a nasal stenosis and a hearing defect. Base of the skull, there can be cranial nerve dysfunction. Going to the histopathology and the other details. This was found by Bill Roth 1959 and was called a cylindroma. This itself is an exam slide for us because of the cylindrical arrangement of the tumor cells. Hyaline stroma, an extremely important keyword in the diagnosis. Nuclei are angulated. Cytoplasm is scanty. Biphasic, composed of ductal and the myoepithelial cells. Now, what we had seen histologically is cyst-like space. They are not true cysts and they are surrounded by the basaloid cells. Normally, a cyst should be a cellular, there should be a cellular lining and a basement membrane for it, which is not there, and hence it is not a true cyst. Tubular, which is the shape of the nest of cells surrounded by a hyalinized. Solid, basaloid cells in sheets. Mitosis can be increased, necrosis will be more. It is an aggressive lesion. And mitosis can be up to 10 per 10 high power field, thanks to Ackermann. The patterns, as I mentioned here, it can be tubular, it can be cribriform, it can be solid. Look at this. A fantastic picture as such, thanks to the producer. The reference is given in the next slide. The cribriform pattern. So, my professor used to say it as sieve-like. Sieve is something that is used to filter the flour that is used for the kitchen purposes. The larger grains are retained, whereas the fine powder goes beneath. It has got exactly the appearance of a filter. And these are all pseudocysts. They can be filled with mucoid globules. Look at this, mucoid globules. And an important one will be the hyaline membrane. Wherever you see, the entire lesion is being covered by the hyaline membrane. And this, of course, is a supporting stroma. Any lesion as such, it should have a supporting stroma. There are normal fibroblasts like this. Take this one, again a cribriform pattern. Again a cribriform pattern. Glands of varying sizes come covered by this basaloid cells. There can be areas of necrosis. Now look at this one. It is indicating a perineural invasion, and contribution is by this Binzu, MD, PhD. Amazing, amazing pictures. We cannot get anything better. Hats off to them. It is their publication. We are only learning from. And as I had told you, there are some structures. There is a structure over, and around that I am finding the tumor cells. So this is a nerve bundle, and around that there is the tumor. This is called as perineural invasion. Earlier, it was described or assumed that the tumors go inside a sieve-like space by means of capillary action. But then there are some schools of thought which say that it is by perineural lymphatics. All said and done, the spread has started. And the beautiful reason for them presenting it is the nerve bundles are also being involved. Perineural and even intraneural invasion. A fantastic picture. And this is the fibrocollagenous connective tissue. So I think the point is clear. This is yet another pattern. Here again, a very organized one. If I see one half, I need not see another. I am finding multiple tubules of, say, almost the same size. This can be a tangential section probably. But as I told you, there is a hyalinized stroma. Hyalinization of the stroma is the key. The cells are otherwise cuboid. They have a scanty cytoplasm. So this is a tubular pattern. We had seen an adenoid cystic and then a tubular. So this again, what is the difference? I am not able to see much of a glandular space, no adenoid cystic pattern, no tubular. It looks like a solid column, something similar to a basal cell carcinoma that is infiltrating. Basaloid cells, hyperchromatic nuclei, scanty cytoplasm, closely packed in nests, and sometimes there can be anastomosis between the adjoining nests. And here again, there is some kind of a basophilic degeneration that is there in the stroma. That is it. But still, if I look for, I might be able to see a hyalinization of the stroma. This is a solid variant. It is presumed to be more aggressive than the other. The immunohistochemistry will be, all these markers can be used. Positive for smooth muscle actin, SN-RED, vimentin, MIB, and CD117. Receptor for tyrosine kinase. The grading runs like this. Grade 1, there is no solid component. The grading is based only on the solid component. Grade 1, no solid. Grade 2, less than 30% is solid. And grade 3, more than 30%. So these are the references which I would like you people to kindly go through. There are wonderful references and it is worth reading the entire article if time permits. The treatment is by resection. Always, when it is well circumscribed, it is easy for the surgeon. But the head and neck are difficult areas because of the nerves. And radiation is a second line of treatment after the surgery. The prognosis is still good. 5 years, more than 75% of the cases. In the case of neural spread, it is poor. In case of solid tumors, it is more aggressive. And when it is large, more than 4 centimeters, it is poor. The complications are recurrence, facial palsy. The differential diagnosis, mucoepidermoid. We can again see glandular spaces with mucinous material. Polymorphic or pleomorphic adenoma can be the differential diagnosis. Mention the sites where you can get a cribriform pattern. I'm not saying the adenoid cystic carcinoma. I'm asking you for the sites so that when a history is given, you people are able to go to the diagnosis. We shall glide to the next slide. Instead of a slide, I had given a specimen. An 8-year-old boy had delayed milestones and was brought to the emergency unit. A surgery was performed. What are your findings? What is the organ? What are the findings in this? You should do your homework and again come back to the class. Thank you for your patient listening.